my name is Morgan Harrington, National Manager of Programs here at American Liver Foundation. I am so excited to be joined today by Dr. Nahel Elias, an abdominal transplant surgeon at Mass General Brigham Hospital for our program today. The liver and heart connection, why some patients need a heart and liver transplant. Dr. Elias, we are so grateful to have you join us today to explore more about the liver and heart connection and how some individuals may end up needing both.
Thank you very much, Morgan, for the invitation, and thanks for everyone who's watching. We really appreciate the efforts of the ALF and the Liver Foundation doing amazing work taking care of and advocating for patients needing liver or managing with liver disease and needing liver transplant. So I'm glad to be here, and thank you for the invitation.
Absolutely. So I'd love to jump right in today and kind of just get started where it all begins. Can you explain some of the underlying heart and liver conditions that might make a combined transplant necessary for people?
Absolutely. So most patients who need a combined heart and liver transplant, or we should say liver and heart transplant, it's the Liver Foundation, right? Our patients primarily, majority of them have heart disease primarily, but that is also affecting their livers. This condition is called cardiac cirrhosis. So as we know, cirrhosis is one of the diseases that's commonly seen with advanced liver disease, and it has multiple causes like alcohol, hepatitis, or metabolic-related steatotic liver disease. And cardiac cirrhosis is one condition where a majority of these patients have had congenital heart disease that they were born with. For example, single ventricle heart defect or hypoplastic left heart syndrome are two of the common ones that we see. And many of these, when they're born and they're young babies, they have an operation done to correct some of the cardiac defects they have. Commonly, one of the operation, for example, for the single ventricle heart defect is Fontan procedure. And the Fontan procedure, unfortunately, after many years, as these kids become adults, or sometime when they're young adults or late teens, they develop liver disease because of the pressure that's generated in this. So while the Fontan operation corrects the congenital defect and maintains these patients to survive and do well for many years, it does cause congestion onto the liver. So the blood backs up from the heart into the liver, causing liver disease, or what we call cardiac cirrhosis, as I mentioned. There are other conditions like restrictive or constrictive cardiomyopathy also that causes similarly cardiac cirrhosis. And there are also rarely situations where the patient has heart disease and liver disease separate from each other. Now, they could be related. So, for example, ischemic cardiomyopathy, commonly seen with patients who've had multiple heart attacks, has very similar risk factors to metabolic dysfunction associated steatotic liver disease. Obesity, type 2 diabetes, kidney disease, high blood pressure, dyslipidemia. These are all risk factors for both diseases. And now you will have the patient with two separate entities that are causing their heart and liver to not function well and necessitate them to need a heart and a liver transplant in a combined situation.
That is some really great information and kind of leads me to ask the next question of when patients are maybe on the wait list for a combined transplant, what are some common things that people should expect? And then does one organ prioritize where they sit on the wait list more so than the other organ if they do need maybe a liver first and then experience cardiac concerns or vice versa?
So I'll address the second point first. Patients who need both a liver and a heart transplant are listed and they show up on both the heart waiting list and the liver waiting list. But the heart or the liver, whichever is higher on the waiting list, will pull the other organs with it. So that's what commonly we see in these situations. And as I mentioned earlier, given the majority of these patients have heart disease as the primary driver for what's going on, they tend to be higher on the heart waiting list than they are on the liver waiting list. And that's when they get an offer for the heart, it automatically pulls the liver with it. So as long as the deceased donor where they got the offer for the heart has a liver available and a good liver ideally, both organs will go to this patient. So either organ will follow the others. And rarely we do see situations where a patient has a high enough MELD score. As we know, the MELD score is the way patients get to the top of the liver waiting list. And the MELD could pull a liver with it, but it's more commonly to see that the MELD is pulling the heart with it, but more commonly is seen where the heart is pulling the liver. Now, while these patients waiting on the list, as you were talking about earlier and asking, their primary physicians managing them for their liver disease and heart disease, their hepatologist and cardiologist ideally will manage their liver and heart disease. And it is crucial for the two teams to work together and coordinate together in taking care of the patient to manage the symptoms of both and assuring that the patient remains a good candidate while on the waiting list. That's very important to make sure to coordinate the care. And this is where we want to maintain the patient to be ready and to get a transplant, because obviously it's difficult to predict when the offer will come, and we want to be ready from our end and from the patient's end. So this is where centers like ours at Mass General, Brigham, with large liver and heart transplant volumes and experience and expertise can really help taking care of patients on the waiting list by coordinating the care, and we do this routinely. And this is important to optimize their outcomes while they're waiting and after their transplant as well, because it is affected by how they're doing while they're waiting.
Yeah, and you brought up a really good point. You mentioned that, the post-transplant care is also really important. And I'm curious, with a combined transplant, obviously complications can be increased. So, what are some of the more common early complications that would be related with a liver and heart combined transplant? Or what happens if one organ starts showing signs of rejections while the other one is still doing really well?
So what's most commonly seen in these situations after transplant, when one organ has signs of rejection, is that the body rejects both organs at the same time. And as I tell the patients all the time, rejection is a bigger word and a scarier word than what actually is happening. We call them rejection episodes. Rejection happens, we can reverse it, we can treat it, we have treatment for it. What rejection means is that the anti-rejection medication, or what we call immunosuppression, are not enough controlling the immune system from fighting the organ. And when you get a rejection episode, the organ is not only being fought by the immune system, but also it hurts, it gets, injured, if you will. Mm-hmm. Now, that said, we can reverse that, especially in liver. We do really well reversing rejection in liver. And as we know well, livers recover from injury very well when they're healthy, when we're taking care of them, that patients recover from the insult that happens with rejection. So we can reverse rejection. And another advantage to these patients is actually the liver, because it is more resistant to rejection, as I mentioned, compared to the heart or other organs like kidney. Having a liver transplant along with another organ transplant from the same donor tends to protect the other organs. So we've seen that patients who had a combined heart and liver transplant are less likely to have heart rejection compared to patients who had a heart transplant alone. So the liver is protective. We've seen that in kidney as well. And it is a larger organ that it absorbs. So part of the rejection is an antibody process, or it's cellular process. So certain types of lymphocytes or white cells in the blood that are circulating and cause the rejection by injuring the organ are attacking the liver, and essentially think of it as having to fight on two separate fronts that dilutes the effect of the immune system harming the organ. Other outside of rejection, other complications still happen, and the common complications that we see with heart and transplant and with liver transplant could still happen to these patients. Most importantly, early at the time of the transplant, the transplant is commonly done heart first, then liver, and the heart has to recover from the injury that he went through and has to function really well in the patient for us to be able to do the liver transplant immediately after a heart transplant. Again, that speaks to the experience and expertise in certain centers where we do larger numbers of these dual transplants. And it is important to support the patient well, and sometimes the hearts are not recovering well enough that we have to use some additional support for these patients and pull them through the liver transplant while they're on support. So there's a lot to say about the recovery immediately after heart transplant for these patients to do well enough and tolerate the liver transplant, given you're talking about two major operations happening back to back, one at the other. Some of the other complications that we see long-term beyond the immediate post-operative course, like issues with the bile duct or issues with the vasculature to the liver, still could happen, and we can manage it and we can control it. And then there are, on the long run, the side effects of some of the immunosuppression medication and using that for long term. And this is where some of the research work we're doing on minimizing immunosuppression, for example, is potentially a big piece to help patients where they will have less long-term side effects from using immunosuppression after transplant.
Yeah, and that's such a great area of research to speak on as well. I do want to backtrack a little bit. You mentioned briefly about how the heart is typically transplanted first, and that has to take a little bit of time to heal. So you also mentioned earlier that having the same donor is really critical in order to minimize rejection and other complications. So how does that organ preservation work then when someone is going through a dual transplant with their liver and then their heart and then needing to wait for that liver to be transplanted?
Excellent point. Excellent question, Morgan. So as I mentioned earlier, these organs come from the same donor. The heart is recovered and then the liver from the donor, and they're brought to the recipient hospital. Many times these come from outside hospital or from our own hospital here. And the hearts are preserved and the livers are preserved using most commonly special preservation solution that replaces the blood within the organ, but the organ is placed within this special preservation solution, the fluid, in a cooler on ice. So that's the most common way that we protect and preserve organs. And that traditionally used to be the only way we protected organs before a few years ago. So while the organ is outside the body, this is what we call ischemia, where there is no blood flow to the organ. So there's no oxygen delivery. This is why we keep it cold, because at lower temperature, the organ requires less, there is less cellular function within the organ cells. And that's where ischemia is less harmful, because the organ needs less oxygen. And when we're delivering zero oxygen, it is protected. And over the years, we've figured out from a lot of research that the hearts are a lot more sensitive to ischemia compared to the livers. Both organs, and all organs are sensitive to ischemia, but hearts are more so than livers. That we transplant the heart first in this situation. So the heart goes in first, and then the liver to follow. So the liver will be on ice for a few more hours longer than the heart commonly. As I mentioned earlier, we want to make sure the heart is functioning well before we transplant the liver. Now, what's also relevant and more recently within the past few years, there've been a lot of work on what we call normothermic preservation pumps. So these are pumps that instead of just keeping the organ cold and on ice, we pump blood and oxygen and nutrients into the organ while it's preserved. So it's no longer ischemic. It's no longer cold. It's no longer lacking oxygen. And even as I said earlier, we deliver nutrients to the organ while we're preserving it. This has given us those pumps that have evolved over the past few years have made it significantly better outcome for certain types of livers and for longer preserved livers. So we are able to take livers from further away. We're able to preserve them for a longer period of time. We're able to use, if you will, lesser quality livers, from older patients or have some fat in them or some, because the insult to the liver, the ischemic insult is decreased, that these patients are able to tolerate these livers and do well with them. And for something like dual organ transplant, it made it significantly better because now we can preserve the organ longer, and we're not pushing to put the liver in. If the heart is not functioning well, can we support the patient for a few more hours, get the heart in better shape, and while we're preserving the liver for an extra few hours, and the liver is not hurting because it's not ischemic anymore. So this is where we've been able to use these special devices, and a few of these devices have been FDA approved over the past few years. We've done some of the earlier research with those, and we've gotten some excellent results, as I said, and that's where we use them very commonly in dual organ transplant.
This question might be a little bit loaded, so I know that this is not going to be a blanketed response, but what is, I guess, a kind of a rough estimation of the time between heart transplant and liver transplant, especially when you're using something like a perfusion machine like you're just discussing? What are those alternatives if someone is having more cardiac related complications post-transplant?
So we've gone as long as 12 to 15 hours with the liver after removing it from the donor body. We put it on the machine immediately and we're able to preserve it. In the old days when I started in this business 20 some years ago, it was very common that we wanted to transplant the liver within 8 to 12 hours after removing it. And for hearts, that time was 4 hours. Nowadays, those times have extended and we're able to, if it's not the right time to do the liver and maybe the heart can get better within a few hours, we're able to use the machine up to there's some of the research that's been done on these machines have gone as long as 24 or even 36 hours, arguing that you can preserve the organ that long. Obviously, we don't want to sit on it unnecessarily. So if there is a good reason where there's a heart is not doing well and we can support the patient to do better and potentially does better, the patient does better a few hours later, we can transplant the liver at a better optimal time for the better outcome.
Yeah, that's such incredible research. It's such a testimony to why research is so important in healthcare still. Um, two last things that I want to talk a little bit about. One is the possibility of recovery from liver failure that is related to, heart complications or vice versa. So, we've got hepatopulmonary hypertension. Would someone be able to have just a heart transplant and have their liver recover, or vice versa? If they were experiencing heart failure related to cirrhosis, could one outdo the other? So if they maybe are experiencing that cirrhosis, could a heart transplant allow for some level of reversal, since, as you mentioned, the liver does regenerate and heals quite well and is able to absorb some of that trauma?
Yeah. No, a great point, a great question there as well. And it is possible if the organ damage is reversible. So this is where when patients are it's a very common recommendation for both a patient who's being evaluated for liver transplant or a patient who's been evaluated for a heart transplant to evaluate the other organ and make sure that that organ is functioning well, that the patient can tolerate a single organ transplant and does not need both. So the key point here is reversibility. And as I mentioned earlier, and we talk about certain damage to the liver that is reversible by eliminating the source of the damage. So, for example, patients who have some scarring in their liver or some fat in their liver related, you know, to either alcohol or hepatitis, you treat the hepatitis. We like, for example, what we've seen with the treatment of hepatitis C and some of the newer agents that's been available within the past 10, 15 years to treat hepatitis C, that nowadays we transplant very few patients for hepatitis C, where we used to be the main indication for liver transplant when I started doing liver transplant. And this is where patients in general are able to have their scarring of the liver, which was fibrosis, which is the damage that happens, is reversible as long as the insult or the cause of the insult is removed. So if
Mhm.
it is hepatitis, it's cured, or if it is alcohol, the patient is abstinent, and that's where scarring of the liver is reversible. Now, advanced cirrhosis is not reversible. So while we've seen some early cirrhosis, so fibrosis is what scarring is, and it goes from fibrosis to bridging fibrosis to cirrhosis. And if it is advanced cirrhosis, especially if patients have symptoms of cirrhosis, so patients who developed ascites and have fluid in their belly, they have uh, uh, other signs of portal hypertension like varices, or they had bleeding varices. This is usually an advanced state that is not reversible. So this is where we're talking about the situation of cardiac cirrhosis. So if heart disease is the culprit, and that's why the patient has cirrhosis, if they have advanced cirrhosis, usually fibrosis is graded most commonly on a 4-stage scale. So if you have F4 or cirrhosis, that's when it's commonly recommended to get a heart and a liver transplant combined. If you have F2 or F1 fibrosis, it's probably reasonable to consider a heart transplant alone. I mean, a heart transplant alone. If you have F3, this is where it's, somewhere in between. So this is where patients who have liver disease or are at risk of developing liver disease or have signs of liver disease, their livers need to be assessed well, either with a biopsy or, we do fibroscans, we do other testing. If they have signs of portal hypertension, this is advanced enough that they need a liver with the heart, and the heart alone is not going to fix the problem. On the other hand, the cardiac complication from liver disease, where the patients may require a heart transplant with the liver, this is another piece again, and it's very commonly because of the magnitude of the liver transplant procedure. We want to make sure the patient can tolerate it and they have a strong enough heart to tolerate undergoing a big liver transplant procedure. So the portopulmonary hypertension is a complication you mentioned, and one of the complications we see. And we know that early low level of pulmonary hypertension is reversible. And this is where some of the medication we use, to treat portopulmonary hypertension, if they're able to decrease the degree of pulmonary hypertension and they control it, that means it's reversible. And when you do a liver transplant, it's going to be reversible even further. Unfortunately, again, if the disease is progressed and is fixed at a point that you cannot reverse it, that's when patients are not going to do well with a liver transplant alone. And they likely will have complications from the liver transplant following following doing a liver transplant alone because of the severe portopulmonary hypertension that they have. So it is important to assess that appropriately. And some patients, it's rare that we do heart and liver transplant, but it's been done where a heart, lung, and liver transplant for severe portopulmonary hypertension in an advanced stage situation.
I really appreciate you wrapping that up with kind of it's a really case by case basis, and it truly depends on where the patient is at in their disease state as well. As we just continue to wrap up, I do have a little bit more question about sort of the coordinated care approach or the multidisciplinary team approach and the importance of this, if there was some advice that you could give to a patient who was coming in to really be able to advocate for their health, maybe they don't have access to Mass General and the incredible network that you all have, what are some ways that you might encourage a liver patient to really ask for that coordinated care if that isn't being offered to them at this time? Maybe their team doesn't, prioritize making sure that their cardiac health is in as great of shape right now. What is some advice you would give to a patient in that situation?
So as I tell all my patients, you got to trust me for me to take care of you. And that's really the crucial piece in here. And when you're talking about a complex care situation like a liver transplant or a heart transplant, or even more complex like needing both together, you really have to have teams that work and coordinate together and work well together. Uh, and and this is where having the experience, having the expertise adds to it. But at the bottom line is, the trust and it takes a lot. I mean, as one of my teachers when I was a resident told me, patients are called patients for a reason. They have to be patient. And that's where, while we appreciate taking care of them, and I know every patient I've transplanted have appreciated their organ that they received, because it is a gift and it is a true situation where, we can't, we're trying and we're doing a lot of work to help every patient who needs a transplant get a transplant. But at the end of the day, we don't have enough organs for everyone. So it is very important for us to work together as a team. We're talking the team is not only the physicians, but the physicians with the patient together. So and transplant of all healthcare fields is the largest team sports that we do. And we work very closely between surgeons, hepatologists, other providers, nurses, nurse practitioners. We work with the dietitians, with the social workers, with the coordinators. So we have a huge team, and that team is essentially doubled or more when you talk about dual organ transplant. And those teams have to work together, have to connect together, and the patient has to be an important part, has to advocate for themselves, and has to work with us and work with the compliance onto the advice that we give them. We learn a lot, we've done a lot, and transplant is relatively a young field. 50 years ago, 60 years ago, transplants were very rare, if any. And now, as we expand and do more, and we're looking for more opportunities, we're taking on more sicker and riskier patients because we have the ability to take care of them. So it is very important for us to work together, and that will be my message to every patient. Work with your team, make sure your team is working with each other and coordinating well. And that's how we're gonna get the best outcomes and the best results.
Yeah, and like you mentioned, it starts with trust. You have to be able to trust the people who are fighting for you. So, well, I really appreciate you taking time today to be here with us and be able to give a little bit more insight on this liver and heart connection and, just different ways that this transplant can take place and really how to have successful outcomes. So, thank you so much for being with us today.
Thank you for having me, and thank you for all the work the ALF does to take care of patients and advocate for them.
Thank you.